talk is specifically looking at pregnancy pharmacoepidemiology, which means the study of medicine use in pregnant populations. And my talk's called Between a Rock and a Hard Place, weighing up the evidence for antidepressant use during pregnancy. And it was named as such because a Mumsnet contributor detailed how she felt that she was between a rock and a hard place when choosing between whether she stays on antidepressants while she was pregnant or whether she comes off antidepressants and suffers with untreated depression until the end of her pregnancy. So thousands of people who can become pregnant suffer with the same difficult decision every year in the absence of really good quality evidence. So I'm going to briefly talk about the last 100 years in drug safety and pregnancy research, followed by antidepressant use and depression prevalence, and what we know about their safety during pregnancy. Some of the issues of the data that we use to build safety profiles around drug use during pregnancy, and what we as researchers are doing to try and improve the quality of evidence for women if they find themselves pregnant and depressed. So over the last century, a handful of drugs and chemicals have been identified to be extremely toxic to the developing fetus if taken during pregnancy, and these are called teratogens. Now, thalidomide is probably the most famous teratogen, and I'm going to talk about that alongside 3 other scenarios that have really shaped our understanding of fetal safety and drug use during pregnancy. So teratology, or the study of teratogens, wasn't officially coined as a research area until the 1930s, when a series of studies done looking at vitamin A deficiency or vitamin A surplus in pregnant pigs identified that offspring from these animals had high rates of birth defects. And what we realised was that optimal maternal vitamin A, so not too much, not too little, was really crucial for the healthy development of a baby in the womb. Now, following these studies and several more over the subsequent few decades, following the release of the drug isotretinoin, which is structurally similar to vitamin A and used to treat severe acne, which creates higher levels of vitamin A in the body, is not used during pregnancy because it carries a 29-fold increase in risk of birth defects. Now, 29-fold increase in risk is a relative risk, and what this means is it's a 29-fold increase in the absolute risk in unexposed pregnancies. So in regular unexposed pregnancies to isotretinoin, the rate of birth defects is about 1.2%. But if exposed to isotretinoin, this increases to about 35%. So following these studies and the end of the Second World War, the Nuremberg Code for Ethical Testing in Human Subjects was established, and the first randomized controlled trial of a pharmaceutical was done. However, at this time, it wasn't required by law that drugs would be tested for fetal toxicity prior to drug rollout. So by the time thalidomide was brought to market, such tests hadn't been done. So thalidomide was marketed in the UK in 1958 as a sedative called Distaval, and it was hailed as a wonder drug because at the time, the only sedatives available to people were drugs called barbiturates, and these were really easy to overdose from and extremely addictive. Now, shown here by this advert from the BMJ, the safety of thalidomide in children was actually a selling point of thalidomide. This child's life may depend on the safety of Distaval, because if they'd gotten into the medicine cabinet and got their hands on thalidomide, that was a lot safer than if they had gotten their hands on barbiturates. And as thalidomide started to be used as a sedative, it was realised it was a really good antiemetic, which means that it was good at stopping people feeling nauseous. And it started to be used in pregnancy for morning sickness because a selling point was that it was safe in children, so it's probably safe in pregnancy. And thinking back to those vitamin A studies, they were emulating scenarios that were toxic to adults. So it didn't make sense that something that wasn't toxic to mum would be toxic to her developing fetus. Obviously, we know that that's not true anymore. As thalidomide started to be used in pregnancy for morning sickness, the rates of birth defects went up. And epidemiological studies, so studies of populations, revealed the cause just a few years later to be thalidomide. And thalidomide is associated with a 43-fold increase in risk of birth defects. So that takes our absolute risk in unexposed pregnancies of about 1.2% up to 50% of pregnancies exposed to thalidomide resulted in birth defects. And it was withdrawn from the market in 1961, and we're still dealing with the repercussions from the thalidomide tragedy today. So following the tragedy, the Committee on the Safety of Drugs was formed in 1963, and it laid out a series of recommendations that suggested that drugs should be tested in multiple pregnant animal species prior to drug rollout to identify these huge red flags for teratogens. And these studies were actually done retrospectively for thalidomide, and it was revealed that they did cause birth defects in multiple pregnant animal species, suggesting that had these tests been done, the thalidomide tragedy may have been averted. Unfortunately, around the same time, prior to the committee laying out these recommendations, diethylstilbestrol, or DES, was being marketed to women to prevent miscarriage. Now, DES is structurally similar to estrogen, and it was first discovered in 1938 and was used for the treatment of menopausal symptoms and prostate cancer. And in 1947, it was marketed to women to help prevent miscarriage in those who were struggling to conceive. And this advert from the 50s actually suggests that all pregnancies should be treated with DES because it was so successful at preventing pregnancy loss, which later turned out not to be true. But as the daughters of the women who had taken DES during pregnancy became adults, it was realised that DES was associated with an increased risk of fertility problems in their daughters and also a higher risk of cancer. And it was withdrawn from the use in pregnancy by 1971 and was actually completely withdrawn from the market for all uses by 1999. So following these two really awful things to happen, it became clear that not only did we need better pre-marketing testing for drugs, we also needed better post-marketing surveillance to continue watching whether drugs were causing problems in pregnant populations so they could be withdrawn and really limit the damage that they were doing. So in 1990, ENTIS was founded, which stands for the European Network of Teratology Information Services, and they aimed to improve surveillance of drugs so that they could be withdrawn as quickly as possible from the market. The most recent drug to be withdrawn for use in pregnancy is sodium valproate. So sodium valproate is a mood stabilizer, and it was licensed in 1962 for the use of treatment for treating epilepsy and later bipolar disorder and other disorders. And it was known to be a teratogen for a long time, particularly of the spinal cord. And doctors would weigh up the risk and benefit to both mum and baby based on the risk associated with sodium valproate and birth defects, as well as the risk to mum and the baby if she had untreated, uncontrolled epilepsy and seizures. Now, it took a long time for this to kind of be recognised, and it's back in the public eye at the moment because it's sort of emerging that women weren't properly informed that this risk was being assumed on their behalf, and they weren't properly informed about exactly what risk they were assuming. So, unfortunately, sodium valproate is often compared to thalidomide in the media, and this was published in The Guardian just last month. And the reason this is slightly problematic is because sodium valproate is used to treat a chronic, lifelong condition like epilepsy. And for some women, sodium valproate is actually the only thing that can manage their epilepsy. So it's a far more nuanced situation than just being able to withdraw it from the market, because some women actually rely on this drug for a healthy life. So it's an ongoing inquiry and debate as to whether that prioritisation of risk should happen again on women's behalf rather than involving them in the conversation. So now I'm going to talk about antidepressants and depression specifically and jump to a slightly different timeline. So antidepressants as we know them have been around since about the mid-20th century. So the late 80s and 90s was the boom of the SSRI, the selective serotonin reuptake inhibitor. And the first to be marketed was fluoxetine, in 1987, commonly known as Prozac, and it was advertised as like youthful and attractiveness if we took Prozac. I think some false advertising is going on there, but what we do know, it was a really, really good treatment for the treatment of depression and anxiety. So as its use climbed, it became really obvious that we quickly needed evidence that it was safe or not safe to use during pregnancy. And as you can remember, by 1987, drugs were being tested in the pre-marketing phase to see if it was really, really teratogenic. So it was just a matter of waiting for the data to come in on women that had taken fluoxetine to see if it was safe to use during pregnancy. And when this data did come in, it was shown that it's associated with a twofold increased risk of some very rare heart defects, which occur naturally in unexposed pregnancies at a rate of 0.1%. So a twofold increase only increases this up to 0.2%, which is still really, really rare. So once we had data on all of these SSRIs, which isn't an exhaustive list, there are other ones, it became clear that fluoxetine and paroxetine are associated with slight increases in risk of super rare birth defects, whereas the others aren't. And these increases in risk are so marginal that none of these are contraindicated in pregnancy. So doctors will still prescribe these in pregnancy if they're doing a good job at managing someone's depression. So just to zoom out a little bit and think about the overall burden of mental health problems in England. So this survey from 2014, published in 2021, suggests that about 17% of all adults in England suffer from a common mental disorder. And importantly, looking at our group of interest, women of a childbearing age, between 21 and 28% of women report to suffer from a common mental disorder. So they're a really important group to understand whether they can use drugs safely if they were to become pregnant. And reflected in this is that of the 7.3 million adults that filled a prescription for antidepressants between 2017 and 2018, women were 1.5 times more likely to fill a prescription for antidepressants than men. So it's really important that antidepressants are well understood if they need to stay on this medication if they become pregnant. So just to think about antidepressant clinical guidance specifically during pregnancy, if a woman's on antidepressants and she becomes pregnant, if she has mild depression, she's advised to slowly discontinue her antidepressants to a stop. If she has moderate depression, she's advised to switch to a safer drug, so a drug that has more evidence and has been studied a little bit more. And if she has severe depression, she's advised to just stay on the medicines that are well controlling her depression. Now, it's important to note that these characterizations of depression are made on an individualized basis, where a clinician and a patient will have a conversation about sort of history and how well the drug is helping with their mental health and what maternal preferences. So it's not just sort of, as it has been in the past, made on their behalf. And these guidelines come from a place of thinking about the slight risks of birth defects that we looked at a few slides ago, and the fact that some studies have shown that antidepressant use is marginally associated with an increased risk of things like miscarriage, stillbirth, preterm birth, etc. And it's really important that I note that these risks, although they shouldn't be trivialised, are extremely marginal in comparison to the teratogens that we discussed at the beginning, like thalidomide and isotretinoin. So the next important question to ask of these studies and ask of these risks that have been identified is, are these causal associations, so antidepressants causing these increases in risk, or are they just associations? So to help us answer this question, I'm going to talk about the data that we use and how we solve the issues that we come across with this data. So the gold standard for testing drug safety during pregnancy is to use a randomized control trial, or RCT. And these involve recruiting lots of eligible people, randomly assigning them to either the drug under study or a placebo, and then following them up to see if there are more adverse outcomes in the drug group compared to the placebo group. Now, for ethical reasons, we don't enroll pregnant women in these sorts of studies, so we have to rely on observational data to assess drug safety during pregnancy, which basically means we have to wait for people to take the drug while they're pregnant in the population and then compare them to women who didn't have to. So there are three main issues that we encounter when working with this observational data that means that the risk that we observe in the data isn't necessarily representative of the true underlying effect in the population. And these issues are called confounding, selection bias, and missing data. And from now on, I'm going to be using the example of antidepressant use during pregnancy and miscarriage as an outcome. So confounding describes a situation where an exposure and an outcome appear to be associated with one another, even when they may not be, because they share a common cause. Now, to break this down, let's take a totally unrelated example to pregnancy. So we know that smoking increases the risk of lung cancer. And we also know that smoking increases the likelihood that you'll have a lighter in your pocket. If you were to do a study where you wanted to see if carrying a lighter caused lung cancer in a group of smokers and non-smokers, you might find that to be true. But we know that's not true. What's more likely is that smoking increases the risk of lung cancer, and they're just more likely to carry lighters in their pocket. So what you're actually picking up from this exposure outcome relationship is the effect of smoking on lung cancer via carrying a lighter. So what we need to do is we need to account for smoking. So we only look among a group of smokers. And if we look at a group of smokers, they all have the same risk of lung cancer from smoking because they're all smokers. And then you can do your comparison again where you compare those who carry a lighter with those who don't. They might carry matches or borrow one when they need one. And if you do this, your association between carrying a lighter and lung cancer completely disappears because it was originally completely driven through smoking. So going back to our depression and antidepressants example, we know that moderate to severe depression is associated with continuing to use antidepressants during pregnancy. We know that from the clinical guidance. It's also plausible to suggest that moderate to severe depression increases your risk of miscarriage through stress and other symptoms associated with depression. We also know that some studies have found that using antidepressants during pregnancy increases your risk of miscarriage. What isn't yet clear is whether antidepressants causally increase risk of miscarriage, or whether we're just picking up the association between depression and miscarriage via antidepressants. Now, this is called confounding by indication, where the reason for taking the drug is confounding the relationship between the drug and the outcome you're interested in our case, miscarriage. So similarly to the smoking example, we want to account for depression so it's no longer confounding our relationship, and then we'll get a better idea of the true effect of antidepressants on miscarriage. So a Danish study did this, where they compared taking antidepressants during pregnancy and not taking antidepressants during pregnancy, first without accounting for depression, and they found that antidepressants caused an increased risk of miscarriage. Then they redid their comparison, but this time only looking among women who'd recently been diagnosed with depression, so accounting for that depression, and they found no difference in risk of miscarriage between those who took antidepressants and those who didn't. So their findings beg the question, do antidepressants causally increase the risk of miscarriage, or are they just a proxy for depression? So lots of other characteristics can act as confounders that might be imbalanced between our two groups. Remember the randomised control trial that we talked about a few slides ago? Confounding isn't a problem in this situation, and that's the reason that they're so powerful and are the gold standard. When you're randomly assigning people to the drug group or the placebo group, you're naturally balancing the characteristics between the two groups. So at the end, the only thing that differs between those two groups is the exposure. We don't have the luxury of this in observational data. Groups naturally differ from one another, so we have to balance them ourselves using statistics. So the next issue I'm going to talk about is selection bias, and this describes a scenario where the population that you have in your study isn't representative of the whole population that the piece of evidence you're generating will be useful for. And the best way to contextualise this is to talk about one of the sources of observational data. We talked about NTIS back on the drug development timeline, and it covers countrywide teratology information services that kind of provide 3 overall services. They provide individualised advice to clinicians regarding pregnancy exposures. They create monographs, which are documents that collate up-to-date evidence on drugs and exposures during pregnancy. And they also collect their own surveillance data to do studies to identify potential teratogens being used in the population. So we have one, and it's called the UK Teratology Information Service, shocker. And it works briefly as follows. So a clinician will ring up the service if they need advice on what to do with a patient who's pregnant and might be taking a drug or want to go on a drug during pregnancy. And UKTIS can give this advice, and then they obtain consent from the patient to enrol them on their database to potentially involve them in studies. And then UKTIS will send a follow-up questionnaire on the due date of the baby to find out if the baby was born and if it was okay. So now let's think about the whole population of women who are pregnant in the UK right now. Not all of these women will end up in a UK TIS study. And as you can imagine, lots of them are lost from these studies because either their clinician didn't ring up because they didn't need advice, they knew what to do, they didn't give consent to be enrolled in the database, or they moved halfway through their pregnancy and the questionnaire went to the wrong doctor who didn't know what happened with the baby. So as you can see, the study population that then goes on to generate a piece of evidence about whether a drug's safe during pregnancy happens in a very select group of the big population that we started with in the first place. And what this means is some societal groups are overrepresented in this group, some are underrepresented, and this lack of representation means that the piece of evidence that you generate no longer is really generalisable to the whole population that you're interested in. So one way you can get around this somewhat is to use anonymised health records like the CPRD or the Clinical Practice Research Data Link, which is a UK-wide repository of GP data. And this is a lot better of a cross-section of the general population in the UK than something like a TIS study. And it's really important to note that teratology information services are really valuable services that have a lot of really expert knowledge on exposures during pregnancy, and they provide much more than just these studies. And the studies that they do produce are a really useful piece of the puzzle to build these really robust safety profiles for drug use during pregnancy. So the last issue I'm going to talk about is missing data, and it kind of draws on both of these issues that we have just talked about. So in a really good observational study, to avoid the confounding that we've already talked about, we need to know all of the characteristics that we want to balance between the two groups. We need to have a value for everybody for them to stay in our study. If we don't know what their value is for one of these characteristics, we can't balance it, so we have to lose them from the study. So say we were doing a study on antidepressants, we would want to know all of the people in our study. We want to know their BMI, their age, their BMI, whether they smoke, drink, or use drugs, for example. Now, in a GP record, there's lots of reasons why this information might be missing. We might not have BMI because in a short consultation, if someone's BMI isn't a cause for concern, it might not be taken, and we'll get an overrepresentation of people in our data set who maybe have BMIs outside the healthy range. And we might not have smoking, drinking, or drug use for kind of the same reason. It might not be asked about, or it might not want to be shared. So as soon as we don't have any of these, we'll lose them from the study. So again, our whole population of people in our GP records, the only people that we will retain in our study are those that have a value for all of those characteristics that we want to balance, so we can get that really distilled effect of our exposure on our outcome. And this kind of comes back to selection bias, because the people that we've got left in the study are just people with complete data, which isn't representative of most people. So again, we're lacking representation, and our piece of evidence is again not generalisable. So what we can do in this situation is we can bring people back into the study using those who had complete data to predict what other people's data would have been if we had gotten it. So if we have a 34-year-old woman who has complete data, she has a BMI of 28, she doesn't smoke, she drinks moderately, and she doesn't use drugs, we can use her data to predict what a similar 34-year-old would have said if we had all of her data. So it's not perfect, obviously we're using a sort of prediction kind of approach, but what it does do is it brings people back into the study. So again, we kind of maintain that representation of people that we wanted to get to avoid that selection bias. So I'm just going to briefly talk about what we as researchers are doing to sort of improve on this issue of creating robust evidence for drug use during pregnancy. And that's what I'm doing for my PhD at the University of Bristol. So I'm funded by the Wellcome Trust, and I'm using the GP data that I've been speaking about for the last half of the talk. And I'm looking at the potential effects of antidepressant use during pregnancy on a range of different outcomes like pregnancy loss, birth outcomes, neurodevelopmental outcomes. and really trying to unpick that issue of confounding by indication, where we're not sure if antidepressants are causing these problems or whether it's depression. And in doing so, that will arm women with at least a bit more information about what's best for her based on the evidence of being on a medication during pregnancy or coming off that medication until the end of her pregnancy. And obviously, I'm not the only person doing this. Again, this is a really, really small list of all the institutions, funders, and cohorts that are really driving forward in the methods that allow us to really get the most useful pieces of evidence out of the observational data that we have, as that's the only source really of evidence for drug safety during pregnancy. So yeah, I'd just like to thank all my supervisors, Harriet, Gemma, Diraj and Kaylee, all the pregnancy pharmacoepidemiology colleagues that I've worked with locally and internationally, Professor Sonia Hernandez-Diaz for some amazing slides that I took some inspo from, and to the Pint of Science organisers for having me here this evening. And thank you to all of you for listening. And I just thought I'd signpost a few local and national charities if you've been affected by any of the issues that I've mentioned in this talk. And yeah, please feel free to go ahead and ask some questions on the slide if you'd like. And yeah, thanks so much.